Hello, I'm Jeffrey Dreeben, Associate Editor of the Journal of Rheumatology, welcoming you to my interview with the authors of an important and interesting article from the March 2026 edition of the Journal of Rheumatology. Today, I'll be speaking with Jocelyn Waghorn, Selena Maxwell, and Myles O'Brien, representing all the authors of our featured article titled Association of Frailty with Risk of Osteoarthritis Development, Progression, and Worse Clinical Outcomes in Older Adults. Thank you all for taking the time to discuss the findings of your important paper on the relationship between frailty and osteoarthritis. To get us started, I was hoping that you could explain for our audience which specific factors and variables influence the frailty index score that you used in this paper.
Yeah, I can take that one. So thank you for having us, first of all. This is actually a very common question that we typically get. A lot of people want to know exactly which factor can make the greatest impact on their frailty score. And my answer might not be overly satisfying for the viewers. But I wanted to start off by quickly just kind of giving an explanation of how frailty is measured typically. So generally, there are two main concepts. We have the frailty phenotype, which is more of a syndrome. It looks at physical frailty, so factors such as walking speed, muscle strength, physical activity accumulations. And then our group actually uses the frailty index score, which is what we present in the paper, which is an accumulation model looking at accumulation of health deficits, which helps us to get a sense of the overall health of an individual, especially across multiple physiological systems. So it's not just physical, it's also mental, lots of different chronic conditions. And with this paper specifically, our group had actually previously created a frailty index for the osteoarthritis initiative. So that was a strength that we were able to actually use this within our paper. But that included measures of function, comorbidities or other chronic conditions. We also looked at mental health, vital signs such as blood pressure, and then polypharmacy and self-report health. So how the individual felt about their own health. So this totaled up to about 31 items. It's not an overly intensive questionnaire, but everything's health related and associated with age. And importantly, and this kind of gets towards your question, but all of these variables are weighted equally when we calculate the score. So we're not looking at one over another. We're looking at all of them to create this overarching idea of how healthy the person is or their overall well-being. Um, and it gives us this bigger picture, a capture of this whole health. Now, with people who have osteoarthritis, it might be easy to imagine that they probably accumulate health deficits more so in the functional area or comorbidities. Osteoarthritis is often present with one or more other chronic conditions. So you can imagine that potentially those are the sections within the frailty index scoring that may be driving frailty for them. But again, just kind of to reiterate, the frailty score isn't looking specifically to determine what factors drive the frailty score, but instead it's looking at that overall health. And then we hope to go on to, and actually my current thesis is looking at more of the specifics. So papers will get into like physical function and how that actually influences the frailty trajectories in individuals with osteoarthritis. So we can kind of break it down a little bit more. But the frailty index score, unfortunately, doesn't actually give us the exact factors. Yeah.
Great. Thanks for that overview. It's really helpful to hear what goes into the score. One of the things that I thought was really interesting about your paper was a lot of the previous research has shown that people with osteoarthritis tend to have higher frailty risk. Um, but in your in your manuscript, you actually were looking at frailty as a potential contributing factor to development of OA and its progression. And I was wondering what kind of led you in that direction to kind of look at it from the opposite perspective of other authors in the past.
Yeah, thanks, Jeff. And thank you, Jocelyn, even foreshadowing the next study too. So you're already setting up episode 2 of the podcast. Um, for us, we really position that frailty is this accumulation of health deficits that predisposes somebody to developing further issues. Frailty is kind of like a compound interest in that sense, in the sense that as you accumulate more health deficits, you have a greater likelihood of experiencing even more, and it kind of can snowball. And so, from this perspective, we're really interested in who are those people that don't have OA at the beginning, at baseline of the project, and have especially the OAI, where there's plenty of people with OA risk factors. And then what are some of the contributors to them developing OA rather than somebody with OA then accumulating more health deficits? And it's certainly a chicken or the egg argument as well. But here it's okay, how do we identify those people who have OA risk factors and then overtly develop OA or overtly fall or need surgery or some of these other aspects? So by managing frailty, it becomes perhaps an easier um, baseline aspect to treat before somebody goes and develops over OA, and that can be done through various mechanisms. But I know a very common framework for addressing frailty at baseline is the avoid framework. So activity, vaccines, optimal medication, social interaction, and then diet. And so from our perspective, we're trying to figure out who are those people at baseline that have health deficits. Perhaps what are some of the factors that then cause them to develop OA? And like Jocelyn kind of alluded to, now we're starting to look at what are the underpinnings of people who are frail or not frail, and then what are some of the reasons by which they do develop OA, or what are the reasons by which those people with OA need surgery, and is there different strategies that we can do to kind of prevent that from both a kind of more of an epidemiological perspective, which this paper was more focused on, but also a bit of a boots on the ground style studies and running clinical trials in-house. So um, all in all, by viewing it as like the likelihood of developing a health deficit is greater among those who are baseline frailty, we figured that was our rationale for treating it as kind of the independent variable versus the dependent variable.
Great. That was a great setup for that. I appreciate it. The other thing that I thought was great about your study was you weren't just focusing on one or two outcomes. You really had a nice umbrella of um, patient-oriented outcomes that were occurring, including incidence of osteoarthritis, but as well as on towards end stage, more joint replacement surgery. And given the different variables that you've had as outcomes, I was wondering if you could highlight from your perspective the most significant findings that you'd like our readers and listeners to be aware of.
Yep. I'll jump in for that one. So yeah, as we said, we really wanted to represent and look at osteoarthritis across the whole disease course. And so just a little introduction to the data we used might be helpful. So we used the Osteoarthritis Initiative dataset, which is a multi-center US-based study funded by both like the NIH and other pharmacy partners. And it's an observational longitudinal study that aimed to look at osteoarthritis incidence and progression. And it's a really, really rich data set that has clinical symptoms imaging. And again, they're followed for about 9 years. And so we had this really big wealth of data in order to address this question. So we wanted to kind of find all of the different outcomes that we could out of in this data set when it came to kind of clinical features of osteoarthritis. And so we looked at incidence and then the progression as measured by the knee osteoarthritis outcome score subscores, um, falls as like a consequence of the symptoms of osteoarthritis and again the end stage knee and joint replacement surgery. Um, and just to summarize our kind of main findings is that frailty score influenced both in incidence, all of the outcome scores for the COOS, as well as increased risk of falls. But it didn't seem to really have much of an effect on time to event for knee and hip joint replacement surgery. So we kind of like the biggest takeaway I would say is the incidence and the symptom progression. And so we looked at incidence with multivariate logistic regression model and a zero point 0.1 change in frailty, which just to kind of contextualize, a zero point 0.1 change in frailty is like a transitional state from mild frail to moderately frail or moderately frail to severely frail. So that's why we use that kind of cut point, um, actually increase the risk of developing osteoarthritis by 65 to 73% from 3 to 9 years. And so that's a pretty big impact. And then looking at knee osteoarthritis outcome scores, again, there's four subscores: pain, other symptoms, function and recreational activities, as well as quality of life. And the COOS, it's usually considered like 8 or more point change is clinically significant. And for both quality of life and for function, um, the frailty index score change of again zero point 0.1 would impact those measures by, it was 8 or 9 points. So like a reduction by inclusive 8 or 9 points. So that would be clinically significant. And so it's really important to consider frailty kind of across the course of osteoarthritis, and including considering it as a risk factor.
Thanks. That was a great summary of the outcome measures that you had, as well as the summary of the results that you had. And it really is interesting how you were able to look at across the disease spectrum. Um, and I think you've alluded to some of the future projects that you're hoping to do, but I was also wondering from a clinical perspective, how do you envision clinicians thinking about and potentially applying findings to their current clinical practice, but also how might this area of research influence clinical practice in the future?
Yeah. I have a feeling we'll all probably kind of chime in for this one. Everyone's got their own kind of perspective on it, but we were lucky in this article specifically that we had a very vast co-author list, and all of them kind of came from different medical and academic backgrounds, and also gave kind of the firsthand accounts of why incorporating frailty into common practice is both necessary and beneficial for the population, especially as we're seeing a very prevalent aging population. So our paper specifically highlighted that individuals who are more frail experience these worse outcomes. And I think that kind of highlights the importance of determining baseline frailty, and then focusing resources or individualizing treatment plans accordingly. And this isn't specifically for osteoarthritis, it is in the paper, but I think it can be kind of generalized to various different chronic conditions. And knowledge of this benefit of assessing and measuring frailty. And like Myles said, when you measure it, it's there, and you can use it, it becomes more accessible. It's much more available for the wider clinician population. And I think it also fosters this more collaborative health effort where each doctor may focus specifically on one condition. But if we start to incorporate frailty, it has that whole host of other chronic conditions that you're also assessing for. And it might begin to bring forward this bigger picture understanding of the body and how different clinicians might benefit from working kind of together. I don't know if anyone else has any more to add.
Yeah, I can jump in. And so, like Jocelyn said, we really want to see a frailty assessment and then its implementation of whatever that gives you in pretty much all disciplines of medicine. And we are seeing a lot more frailty measurement being put into clinical practice. Like it's commonly used in like the clinical frailty scale specifically. There's like over 2,000 papers that use it, and it's used in routinely in the health systems of like, for instance, England. Um, so we are starting to see it, but and kind of what's lagging behind is the discipline kind of specific care guidelines and recommendations. Although it is becoming more common, like it's in cardiovascular health has come out with some guidelines. We're working here, other people in our group, to develop care guidelines for primary care. So I think in the future we will see a lot more care guidelines to measure back up kind of frailty measures. And I'm supervised by one of our co-authors, Dr. Ken Rockwood, and so to channel him for a second, um, he there's a lot of value in having people that are really good at treating one condition, but in the future there needs to be more recognition that that other kind of organ systems can influence your condition of interest, and that there's a lot of overlapping mechanisms. And that's also kind of what I'm interested in, is to try to look into the mechanisms of frailty. And we kind of have some hinting that a lot of them are probably in entrenched in kind of the mechanisms of aging itself. So looking at like chronic inflammation, looking at metabolism, and how those can have wide-reaching effects across different body systems.
Yeah, and then to wrap up, I think for me it's kind of 2 points, and I think the first point is maybe a bit of a summary of Selena's anyways, where it's OA is becoming not just a wear and tear disease of a single joint, but rather a systemic issue. We're seeing more and more for this push of there's metabolic aspects to OA, there's cardiovascular aspects to OA, and so frailty becomes this really attractive measure of considering those other systems with OA beyond just simply the knee or the hip or the hand or the site of focus. So treating it like that. And the other thing is that as researchers, we really try to separate the noise from the signal, especially with both clinical data and clinical trials, but also things like epidemiology. And for something like frailty, this paper does a really good job of showing that there's a signal there. All of our primary measurements that are really relevant for OA development, falls, surgery, keep showing this pretty good effect size with frailty, showing that, okay, something's going on here that's not just the spurious correlation that we should, disregard. And then I think the really exciting thing will be a bit more chronic condition focused guidelines like those that exist for heart failure and frailty currently. And then from there, it's figuring out ways to make this accessible for the physiotherapist, for the clinic, for the physicians, for the surgeons, for whoever to help guide treatment from there. And I think the nice thing about the frailty index and the one that we've developed is most of the items in it can be determined relatively simply. It's not it's not an expensive imaging test that's required to establish this risk or other procedures. It uses relatively routine data to culminate into a single value. And from experience, the clinicians like the single value aspect of it. They like the simplicity of being able to look at a number and then help guide their care based on that versus a myriad of results to try and comb through. So I think for this, the exciting pathways for us tend to be, very mechanistic for Selena and physical function focused for Jocelyn, and then trying to tie it all together to make sure that our work is having an impact.
Great. Thanks, all three of you. That was a great summary of how you think this could have clinical implications. And I want to thank each of you for taking the time today to chat with us and to review the findings of your articles on the association between frailty and osteoarthritis risk. To our viewers and listeners, please read the article titled Association of Frailty with Risk of Osteoarthritis Development, Progression, and Worse Clinical Outcomes in Older Adults, which is available on the journal's website at jroom.org. That's jrheum.org. And it's included in the March 2026 print edition of the journal. Thank you for joining us today. I hope you'll tune in next month for another featured interview with the authors of an article that is of particular interest from the April 2026 edition of the Journal of Rheumatology. We'd love to hear your comments on X using our tag JRoom, or you can reach out to us by email at manuscripts@jroom.com. Thank you.